Okay, great. Good morning. My name is Connor Darby. I'm the director of the UCLA Forensic Psychiatry Fellowship Program. I'm very excited today to introduce this new Forensic Grand Round series entitled Psychiatry, Law, and Ethics, which is the brainchild of the UCLA Forensic Psychiatry Fellowship founding director, Dr. Robert Bob Weinstock. I was fortunate to work with Dr. Weinstock early on in my residency as an intern, and he opened my eyes to the fascinating world of forensic psychiatry, as well as the unique ethics challenges and dilemmas that face psychiatrists at the intersection of psychiatry and law. Dr. Weinstock approaches these important issues with a passion, energy, and doggedness that is unmatched and which inspires others to follow suit. Dr. Weinstock encourages original thinking and new ideas from trainees and mentees, and he's often described how much he enjoys challenging questions and welcomes being stumped because it forces him to rethink and reanalyze his positions. It is an honor and a dream of mine to now be in a position to co-run the Forensic Psychiatry Fellowship Program with Dr. Weinstock, and I think it's fitting that my older brother, Dr. Ryan Darby, of forensic neurology with interest in ethics, who I've looked up to and admired since I was young, and who now has collaborated with us on many presentations, papers, books, and other academic projects in forensic psychiatry and neurology, is the first speaker of the Psychiatry, Law, and Ethics series. So let me introduce our speaker today. Dr. Ryan Darby is an assistant professor of neurology at Vanderbilt University Medical Center. He currently sees patients as the director of the Frontotemporal Dementia Clinic in the Department of Neurology at Vanderbilt University Medical Center. He received his undergraduate degree from Princeton University in psychology and neuroscience and his medical degree from Vanderbilt University. He trained in neurology at Massachusetts General Hospital and Brigham and Women's Hospital at the part of the Partners Neurology and Harvard Medical School program. He then received the Sidney Bear Research Fellowship in Clinical Neuroscience at the Beth Israel Deaconess Medical Center. He simultaneously completed a clinical fellowship in behavioral neurology and neuropsychiatry at Beth Israel Deaconess Medical Center, Massachusetts General Hospital, and McLean Psychiatric Hospital in Boston. Dr. Darby is interested in patients with symptoms at the border zone between neurology and psychiatry. Both neurological and psychiatric patients can share similar symptoms, including delusions, hallucinations, and antisocial and criminal behavior. This suggests that symptoms may share a common pathway across different diseases. However, these different diseases often have neuroimaging abnormalities in different locations, making it difficult to understand how the same symptom could develop. To address this problem, Dr. Ryan Darby helped to develop a new neuroimaging approach to localize complex behaviors to brain networks, rather than specific brain locations. He first studied this in patients with focal brain lesions, showing that brain lesions in different locations causing the same syndrome were all functionally connected to the same brain network. Dr. Ryan Darby's current work is focused on applying this method to neurodegenerative disorders in order to understand why brain atrophy in different locations can cause the same clinical syndrome. He is using this method in combination with behavioral testing to study criminal behavior in FTD patients and delusions and hallucinations in patients with Alzheimer's disease, Parkinson's disease, and Lewy body dementia. Dr. Ryan Darby has received numerous awards for his research, including the Stanley Cobb Award from the Boston Society for Neurology and Psychiatry, the Young Investigator Award from the American Neuropsychiatric Association, the S. Ware Mitchell Award for Outstanding Early Career Investigator from the American Academy of Neurology, and the Norman Geschwind Prize in the Behavioral Neurology. His work is generously funded by the Sidney Bear Foundation, the Alzheimer's Association, the Bright Focus Foundation, and the Department of Defense. I'm very pleased to introduce my brother, Dr. Ryan Darby, and I want to remind everyone at this point to please use the Q&A during the presentation and talk, and also follow at the end of the presentation so we can field questions at that time. Thank you very much.
Great. Thank you so much, Connor, for the wonderful and warm introduction. I'm just going to pull up my slides here. All right. So again, thank you, Connor, so much for the introduction, and thank everyone for having me and including me as part of this. I'm very excited to talk to you about my research on network localization of neuropsychiatric symptoms. So I'll try and focus broadly on neuropsychiatric symptoms and my approach to studying them in patients, and then hopefully we'll have time to discuss some of the forensic implications and how it relates to criminal behavior. And so this interest really began because of my broad interest in neuropsychiatry and behavioral neurology. And the general approach that I take for studying these different disorders is to use maps of the human connectome, so wiring diagrams of the brain derived from functional connectivity in large data sets of normal subjects to understand and to test the hypothesis that neuropsychiatric symptoms localized to functional brain networks, that they are related to these functional disconnection syndromes. And I am particularly interested in several psychiatric symptoms that I'll discuss today, including delusional misidentifications, criminal behavior, and disordered free will perception, so disordered agency and volition. And my interest in these topics and in these abnormal behaviors really began as a resident when I was seeing patients. And I would see patients with very unusual or bizarre symptoms that I didn't understand and couldn't fully explain. And so in this first case, this is a case that I saw early on in my residency with a behavioral neurologist. And I'm going to let her go ahead and let her describe the symptoms in her own words. Hopefully the audio works here, but there are captions as well.
Since you've been back home, how has it been there? How have you felt?
Felt a little strange because it feels that my house was the same as the house I was staying in, which wasn't my house, but they had the same decorations and rooms were all the same.
Everything about the house looked identical to your house.
Yep.
So this is a woman who is describing the unusual sensation or experience that happened when she went home, where the home didn't feel like it was actually her real home. And she was able to recognize that all the decorations looked similar, that the furniture was similar, and that in every respect, it really resembled her actual house. And yet she was convinced that it wasn't the same location, it wasn't the same house. And so this is a variation of Capgras delusion. So this loss of the sense of familiarity that we would normally have for a person or a home. And this case really fascinated me because I had trouble understanding, why was this happening? What could be going on in the brain to lead to this? And as I saw cases like this, I began to recognize other cases, other patients where rather than having a broad delirium or general cognitive issues, they had very specific types of delusions. And so I saw another gentleman who developed the delusion that his son-in-law was replaced by an identical looking imposter. And so this is the more classic description of Capgras delusion, where someone misidentifies a familiar person, a family member, as an identical looking imposter or replica. This patient also had a different delusion, the delusion that his physicians were actually familiar family members in disguise. And so this delusion is called Fregoli delusion, is actually named after not the physician who described it, but after a famous Italian actor at the time who was known for making quick costume changes on stage. And so he would often be in disguise. And again, this delusion happened and was fairly fixed and focused on this physician who he thought was a family member in disguise. And then I finally saw the third case that was maybe the most bizarre example that I saw of this during my residency. A gentleman, a 71-year-old gentleman who believed that his pet cat had been replaced by an imposter cat. And so he said that, his pet cat Frack looked exactly the same as his normal cats, would walk the same, was eating the same food, but he knew there was something different about the cat. It just didn't feel right. It didn't feel familiar. And he was convinced that it was an imposter or a replica. And then developed on top of that, the delusion that that this must be therefore a member of the FBI working in a conspiracy against him. And so we playfully called this Capgras delusion as a play off of Capgras delusion. But these are all, in general, examples of delusional misidentifications. And so these are delusions that are characterized by a misidentification. That's really the hallmark or the content of that delusion. And they focus on an inappropriate feeling of familiarity. And so in some cases, there can be an increased sense of familiarity, inappropriate to things that shouldn't feel familiar. That's what we saw in our second patient with Fregoli delusion, thinking that a physician who is unfamiliar is actually a family member in disguise. We can also see patients who have the opposite of that, Capgras delusion, where they have a decreased or a loss of sense of familiarity. And as we saw in our different cases, this can extend to people, to places like our homes, and also to familiar objects and animals like pets. Now, these are also delusions, so they're characterized by a fixed false belief, which is why this abnormal feeling of familiarity is misinterpreted, and that conclusion is believed despite the fact that it's implausible. So these patients are convinced that there's an identical imposter or that a physician is a family member in disguise, even though that's really implausible. And these are not new disorders to be described. So they've been described for nearly 100 years in psychiatric patients. So most of the first descriptions of these are from psychiatric patients. The challenge is that in our patients, all of these were due to brain lesions. And so in our first case, the 71-year-old female who didn't recognize her own home as her home, she had a large brain lesion in the right ventral front of the frontal lobe that precipitated this delusion. Our second patient had a brain lesion as well. So in this case, this patient with Capgras and Fregoli syndrome had a brain lesion in the right posterior part of the brain, in the parietal occipital lobe. And our third patient, the patient with Capgras delusion, the delusion for his pet, also had a brain lesion, this time in a third location in the right middle frontal gyrus, the dorsolateral part of the frontal cortex in the right hemisphere. And so when people have hypothesized about what is going on with these delusional misidentifications, the cognitive neuropsychiatrists and cognitive neuroscientists, the most common explanation has been a two-hit model or a two-hit hypothesis. And so it's thought that these delusions really require two different types of abnormalities. One that leads to the abnormal perception. So in the case of delusional misidentifications, it's that gain or loss of familiarity, that abnormal sense of familiarity. And that leads to the content of the delusion. And they need a second deficit leading to an abnormality in belief evaluation. So why is this leading to an erroneous conclusion that is then believed, even though it's implausible and despite other people trying to reason that it's unlikely? Now, our cases present a challenge to this, and that all of our cases had only a single lesion, not two. So we didn't see that there was actually a second hidden lesion somewhere else. There was only one lesion in all of our cases. The second challenge is that the lesions happen in three totally different parts of the brain. So we had one in the back part in the parietal occipital lobe, one in the lower part of the frontal lobe, and one in the dorsolateral part of the frontal lobe. And so there wasn't an area that clearly seemed to be responsible or overlapped in these cases. And so we turned to the literature and identified other cases of delusional misidentifications that were caused by or precipitated by a focal brain lesion. And we saw that really across these 17 cases we identified, there was not a clear pattern as to where the lesions were located. We had the majority that occurred in the right hemisphere, but we had a case that was in the left hemisphere as well, in many different parts of the brain. So we had lesions that affected the frontal lobes in different locations, whether it be the ventral frontal lobe or the dorsolateral prefrontal cortex. We saw areas that affected the temporal lobes, some that were in the parietal lobes. Some lesions were large, some were small. Some affected the white matter, others did not. Some were hitting subcortical areas, some did not. And so there was no clear pattern across all of these lesions that led us to an explanation as to what could be going on, what was the brain region responsible for this type of behavior. And so as we were thinking through this challenge, we took a step back and thought about our approach in general to understanding brain behavior relationships. So what has our approach been to understanding these and understanding why neurological symptoms emerge. And the classic approach that we were taking and that many have taken has been the localization approach. And this has been really valuable for neurologists for hundreds of years, for understanding how the brain works, for understanding diseases, and for helping with the diagnosis. And it's the idea that similar symptoms will localize because of damage to the same location. And so we look at patients who develop the similar symptoms, we look at where their brain damage is, and we hope to find that it's the same location across patients. And again, for many symptoms, this has been very, very useful and informative. And it's been championed since early on by figures in neurology, including Paul Broca and Charcot. But we've also known that this approach doesn't give us the answer or the explanation in all the cases. And so there have been other traditions in neurology for understanding how brain behavior relationships emerge and for localizing neurological symptoms. One has been the disconnection approach. And so this is an approach that was championed by Norman Geschwind, the father of modern behavior neurology, but also dates back to earlier neurologists like Wernicke, who were studying neurological symptoms that didn't seem like they could be explained by the localization approach. And what the disconnection model says is that neurological symptoms can also arrive not just because of damage to a specific location, but because of damaging the flow of information from one location to another. And so that can be through white matter connections. It can also be through damage to association cortices, where we see converging network connectivity, where information from many different parts of the brain are coming to the same location, which was one of the advances of this approach championed by Dr. Geschwind. There have also been traditions in more in holistic neurology of really pointing out challenges in localizing neurological symptoms. And a lot of very useful ideas have come out of that. One is the idea that the effects of a brain lesion are not focal. And so that brain lesion in one location can disrupt brain regions that aren't damaged, but are connected. And so that's a phenomenon we refer to as dieschesis. And it's the idea that the neurological symptom may emerge not because of the damage to that one location, but because it's disrupted that connected region. And it's really the connected region that's responsible. The other idea that's come out of this is that certain types of cognitive processes or complex human behaviors are unlikely to localize to just a specific anatomical region. They may result as a dynamic interaction between different brain areas that are connected in a functional brain network. So the idea that symptoms can localize to a network and the function of that network as opposed to any single node within that network. Now, the challenge with these other approaches has been it's very difficult to study this and to really prove that in our neurological patients. And so that's where I had the fortunate opportunity to be doing my neuropsychiatry and behavioral neurology fellowship at Beth Israel, and to have the opportunity to work with two researchers and neurologists, Michael Fox, my mentor on the project, and Aaron Boas, a fellow a year ahead of me, who were working to develop a method to do just that, a method called Lesion network mapping. And so what Lesion network mapping does is it uses the human connectome, that wiring diagram of the brain, that's derived from a large data set of resting state functional connectivity in normal subjects. And so resting state functional connectivity, for those who are less familiar with it, is a type of functional neuroimaging method, a type of fMRI. But instead of looking at a contrast or brain activation associated with a cognitive task like a memory task, we're looking at brain activity at rest over time. And what we're interested in is how that brain activity correlates with brain activity in other parts of the brain. And so in this method, we take a location like the posterior cingulate cortex here in yellow, and we measure that brain activity over time. And then we say, are there other parts of the brain where the brain activity is functionally coupled, where there's a correlation in that functional brain activity? And we can find areas like the medial prefrontal cortex, the MPF in orange, where that brain activity is highly correlated, where we see whenever brain activity in one region goes up, brain activity in the other region goes up, and vice versa. We also see areas that have the opposite relationship, where whenever brain activity in one area goes up, the other area goes down, and vice versa, like we see here in the blue with the IPS. And so based on those relationships, we can say that two areas are functionally connected if their functional brain activity is correlated over time. It tells us there's a functional relationship or connection between those locations. Now, typically in functional connectivity, we're choosing that seed location based on anatomy, and so choosing the posterior cingulate cortex as an area of interest. What lesion network mapping does is it takes the lesion location as that seed, and it measures where is that lesion location connected to in the normal human brain. And so we take the patient's lesion, look at where it's connected to in the normal brain, and then we try and ask the question of, even if these lesions are happening in different spots, are they all actually connected to the same region? Are they all part of the same functionally connected brain network? And is it specific for that symptom when comparing it to other symptoms? And so what this looks like here, we have 3 different lesions in red in 3 different locations in patients with delusional misidentifications. We then have the middle part where we look at where those lesions are functionally connected to. So what is their functional connectivity map? And we see the areas showing positive functional connectivity or anti-correlated or negative functional connectivity. And then in the third column, in column C, we can look at what is the overlap? Are there any regions where across all of these different patients, we're seeing lesions that are connected to the same location? And of course, looking at delusional misidentifications, we have a specific hypothesis. And so our hypothesis is that the lesions would be located to areas of the brain that are important for what we think are the cognitive neuropsychiatric processes leading to this, so that these lesions would be connected to brain regions involved in the experience of familiarity. This would explain the content of those delusional misidentifications, that altered sense of familiarity, and that they would also be connected to areas involved in belief evaluation, so how we are evaluating beliefs and judgments. And that really what would define delusional misidentifications would be having lesions and locations that are connected to both of these types of processes. And so that's what we tried to test in our 17 cases and found that that was the case. And so here in the first part, we see on the top that even though the lesions causing delusional misidentifications occurred in different regions, all 17 of them, so 100% of them, were functionally connected, in this case, anti-correlated, with the left retrosplenial cortex, as well as other regions in the brain. We then, in the green, in the middle part here, performed a meta-analysis of fMRI studies in normal subjects to identify brain regions that seemed to be active or involved in familiarity. So these were studies where subjects were asked to look at a picture of their mom versus a picture of a stranger's mom, or their house versus a stranger's house. And those brain regions that became more active when looking at the familiar versus unfamiliar items or objects were identified. And what we found is that the regions overlap significantly, that what we were seeing is that our lesions causing delusional misidentifications occurred in locations that were strongly connected to these brain regions involved in familiarity that we identified in this meta-analysis. Similarly, we found that lesions causing delusional misidentifications, the majority, so 16 of the 17 cases, were functionally connected to the right ventral frontal cortex. And so, again, we wanted to compare this to locations involved in belief evaluation. In this case, we used expectation violation tasks and performed a meta-analysis, again, similar to what we did before, identifying brain regions that were involved in this task across different types of studies. And we identified the right ventral frontal cortex as an important part of this task-based activation study. And we saw that our lesions causing delusional misidentifications were strongly connected to those regions involved in belief evaluation. And so our next question was, is this specific? And so we were finding that our lesions causing delusional misidentifications were strongly connected, that they were occurring in locations connected to these regions involved in familiarity and belief evaluation, but we wanted to compare it to lesions causing other syndromes, things like hallucinations or pain or aphasia, that didn't have anything to do with delusional misidentifications. And our hypothesis was that it would only be the lesions causing delusional misidentifications that would occur in locations that were connected to these familiarity regions and belief evaluation regions. And so we compared the connectivity strength between our lesions causing delusional misidentifications and our lesions causing these other control syndromes, and saw that that was the case, that our lesions causing delusional misidentifications were strongly connected to both familiarity regions and belief evaluation regions, those in the blue, whereas our control lesions in the red really didn't have strong connectivity to either of those locations. And so it suggests that what really defines or predicts why certain lesions may lead to delusional misidentifications is not just merely where they're located, but where they're connected to. That if they occur in locations that are specifically connected to belief evaluation and familiarity regions, that will lead to a higher likelihood of these symptoms occurring. And so we wanted to test one other analysis of specificity, and that was to compare it to lesions causing other types of delusions. And so we were able to find lesions that caused delusions of jealousy and paranoia. And based on this two-hit connectivity model that we were proposing, we predicted that lesions causing these other delusions would also be connected to belief evaluation regions, that this would be a common feature across these different types of delusions. That was a common abnormal cognitive construct for that, but that there shouldn't be any connectivity to familiarity regions, that this should really be specific to the content of delusional misidentification and not to these other types of delusions. And so we tested our lesion network mapping of these other delusions and found that that was the case. And so when we look at the familiarity regions in column A, these other delusions in blue really weren't strongly connected to those areas, and certainly weren't more connected there than our control lesions. But when we looked at the belief evaluation regions, we saw that that was not the case, that these lesions causing other delusions were functionally connected to those locations. And so it seemed to provide additional support that this symptom is related to where the lesions are connected to, and it's specifically to regions involved in belief evaluation across all delusions, and to familiarity regions, specifically in patients that develop delusional misidentifications, but not other types of delusions. And so with these findings in mind, we wanted to explore other symptoms that were really of interest and fascinating, but poorly understood. And so, as Connor mentioned, a really big interest and passion of mine is understanding changes to social behavior and the development of antisocial behavior and criminal behavior in previously normal patients with neurological diseases. And again, this is an interest that stems from my initial cognitive neuroscience classes as an undergrad and medical school classes, reading about cases like that of Phineas Gage. So many of you are likely familiar with this case, but for those who aren't, Phineas Gage was a railroad worker who had a tamponing rod blasted through his brain. And so you can see the image of his skull here, where the tamponing rod went in through his left orbit, exited through the top part of his skull. And really, one of the most remarkable things about this case is that he survived. This is a gruesome injury that may have killed him, but he survived, and he actually had no clear problems with his motor function, with language, with memory. And yet he was a profoundly different person, and his personality and social behavior had changed. He was described at the time as fitful, irreverent, indulging at times of the grossest of profanities, which was not previously his custom, manifesting little deference for his fellows, impatient of restraint or advice when it conflicts with his desires. And so, as I said at the time, Gage was no longer Gage. He was a different person. And this really prompted questions about the degree to which a brain injury to specific locations could change those fundamental aspects of our personality and our behavior. Now, later, the questions become, in severe cases, can this lead to criminal behavior? And this issue was brought up prominently in the case of the Texas Tower shooter, Charles Whitman, in 1966. And so he murdered his wife, his mother, and killed many other innocent bystanders at the University of Texas before he died. And in the months leading up to this horrific act, he had complained of headaches, of changes to his thoughts, his personality, and wrote in his letter that he was convinced that he had a brain disorder. And so he had an autopsy performed at the time that identified a tumor in his right temporal lobe. And it prompted discussions and controversy at the time about whether that tumor in any way related to his behavioral change and his criminal behavior. In the modern era, this has continued, and with the advent of more access and better neuroimaging, we're actually able to identify these brain abnormalities in persons accused of crimes before death using neuroimaging. And so one of the early examples of this was the case of Herbert Weinstein, who had murdered his wife after an argument. And during his workup, had an MRI scan and a PET scan that showed a large cyst in his left frontal cortex. And so his lawyers used this as evidence to argue for diminished responsibility, that somehow that cyst had contributed to his criminal behavior, had changed his mental state so that he can no longer conform his behavior to the law. Now, again, in these three cases, we have lesions in three different locations. And so in the case of Phineas Gage, the lesion was in the middle part of the frontal lobe. In the case of Herbert Weinstein, it's in the lateral part of the frontal lobe. And in the case of the Texas Tower shooter, it was in the temporal lobe. And so again, it begs the question of, is there a consistent neuroanatomical localization for these symptoms? How do we understand which brain lesions are likely to result in an acquired antisocial behavior disorder, which aren't, and how does that relate to the cognitive processes we think might be important? And so we, again, went through and identified cases of acquired antisocial behavior disorder. So these were patients where in their record was documented to have normal behavior, to have a known onset of a focal brain lesion, and then to develop a behavioral disorder that included criminal behavior. And what we saw is that across all of these different patients, we had inconsistent localization. And so patients had lesions in the frontal lobes, but they could be in different parts, somewhere in the orbital frontal, somewhere in the ventral medial portions, somewhere in the lateral parts of the frontal lobe. We saw some that were on the right side, some left side, some bilateral. Many lesions occurred in the temporal lobes, whether that was the anterior temporal lobe, the mesial temporal lobe. We had some involving deeper structures like the amygdala or the ventral striatum. And so again, across all of these patients, we did not see a consistent localization to say this is the location that when lesioned leads to acquired antisocial or acquired criminal behavior. And so with that in mind, we turned to the lesion network mapping method that we had used to explore delusional misidentifications to see if it could provide additional insight into these behaviors. And what we found was that that was the case, that even though these lesions were happening in different locations, all of them, so 100% of them, were occurring within the same brain network. They were all connected to the same locations. And those included the orbital frontal cortex, the anterior temporal lobe, the nucleus accumbens, ventral striatum, and the amygdala. And on the bottom here, we compared that to the connectivity profiles of lesions that caused other types of behaviors that weren't antisocial or didn't include antisocial behaviors. And we found that it was highly specific, that it was just the lesions that were causing antisocial or criminal behavior that had lesions connected to these regions, to this network, whereas our control lesions did not. And so once again, we were interested in how does this relate to the cognitive processes, to the mental states that may be important for these behaviors? So what are these brain networks that we're identifying associated with antisocial behavior doing? And our hypothesis was that they were related to moral decision-making, that these would be the brain regions that were involved in how we evaluate moral decisions, and that they more specifically relate to some of the neuropsychological processes that we think are important for that. Things like value-based decision-making, reward and punishment decisions, theory of mind, so how we understand and interpret the mental states of others, empathy, so how we have an emotional experience related to what somebody else is experiencing, and cognitive control, so how we can use our executive functions to control our behavior and our behavioral responses. So each of these has been argued to either that it does or does not relate importantly to normal social and to abnormal or antisocial behavior. And so again, we performed meta-analyses of fMRI experiments to identify brain regions that have been implicated in these different processes and compared whether lesions causing antisocial behavior were connected to those locations and compare that to control lesions that didn't cause antisocial behavior. And what we found was that it was the case that our lesions causing acquired criminal behavior occurred in locations that were functionally connected to regions involved in moral decision-making. And so we performed two different approaches for this meta-analysis for morality, identified regions in the green here, and saw that there was overlap in the yellow, and that specifically we saw very strong functional connectivity between lesion locations and regions involved in moral decision-making in the gray in our acquired criminality cases, whereas we saw much weaker or no functional connectivity in our control syndrome to these regions. When we looked at the specific neuropsychological processes that might be important, we saw that it was particularly related to value-based decision-making and theory of mind. And so regions involved in value-based decision-making, reward and punishment decisions, patients with acquired criminality had lesions that were strongly connected to these brain regions. And similarly, we looked at theory of mind. Our patients with acquired criminality had lesions that were strongly connected to these brain regions involved in understanding the mental states of other persons. In contrast, our patients with other types of neurological diseases had lesions that weren't in locations functionally connected to these locations. And yet there were other neuropsychological processes that it seemed like our lesions weren't strongly associated with. And so when we looked at regions involved in empathy, so having the emotional experience related to the suffering of another person, we saw that our lesions resulting in acquired criminal behavior weren't strongly connected to those locations. And similarly, brain regions involved in cognitive control, we saw that our lesions causing acquired criminal behavior weren't strongly associated with those locations. And so, it may be that in our cases of acquired antisocial behavior, that these cognitive processes or that tasks that measure these cognitive processes may miss our patients that are developing this syndrome and may not relate as much to the reasons for why these behavioral changes occur. And so, to bring back to what Connor had mentioned about the forensic implications, I think a big important part of this work is discussing the forensic implications, because I think that those are going to come up and there's a chance of use or misuse of those. And so part of that relates to the predictability. So if someone has a brain lesion in this location, does that mean that they're going to develop that behavior? And I think the answer to that is no. And so we have many, probably the majority of patients who have brain lesions in locations connected to these locations will not develop an acquired antisocial behavior disorder. And so there are clearly factors beyond the network localization that are important. There may be reasons why they have a functional response that's different. There may be other factors like genetic factors, socioeconomic factors, environmental factors, gender and age that importantly relate to whether that lesion is going to lead to that behavior. So I think in terms of predictability, the answer to that is that there's a very low predictability. But there are other places where the relation to criminal responsibility where understanding this may be important. And so if it's to understand the mechanism by which a brain lesion might influence the networks involved in this behavior, then I think the answer is yes, that this can help understand that mechanism. And it may have some utility as a negative predictor. And so it may be that when we find incidental brain imaging findings, if it occurs in locations that are outside of this network or this association with acquired criminal behavior, that's much less likely that that brain abnormality on the imaging is contributing to the behavior. But it's important to realize that what we're not showing is the patient's actual mental state, their actual change in behavior. So the imaging alone is not sufficient to tell us that. What we really need is to test the patient clinically to see that they've had an acquired behavioral change, that it corresponds with the course of their disease, and that we can link it that way. And then to have neuropsychological tests that can support that and other evidence that can support that to show that there is that change. And then I think the final question is, how does this relate to diminished responsibility in these cases? And that's something that the science and the research study can't necessarily explain or answer. So that is a question that we as a society and our laws and our interpretations of those in the court must answer about that normative question. But I think what the science can do is make that a truly informed decision and really assist in that, so that when we're making those types of determinations, we're able to use the evidence to help us with that. And so as we're trying to say, well, what are those brain areas, those brain processes that are really important for maintaining normal social behavior and conforming our behavior to the law, this might be a way of identifying those regions in those processes. And so as a final test of the network localization of lesion network mapping, we turn to free will perception. And so obviously the questions about free will and its existence are very controversial, and scientists and philosophers have debated this for some time. But I think what we experience of free will, and that we all feel that we have it, that's really not controversial. And that perception or that experience has been studied by scientists. And often we divide these into two related components. One is volition, or that desire to make a movement. And the other is agency, so that feeling of a responsibility for a movement after it's occurred. And each of these can be disrupted in neuropsychiatric diseases. And so in neurological patients with disordered volition, we refer to that as, as akinetic mutism. Whereas we have patients with disordered agency where they don't feel responsible for movements that look volitional, and we refer to that as alien limb syndrome. And matching the theme of what we've seen in other disorders, when we've tried to localize this in patients with focal brain lesions that cause these different behavioral disorders, we haven't been able to. It doesn't line up. In the case of akinetic mutism, we see lesions in many different parts of the brain, including the anterior cingulate cortex and the cingulum, but also subcortical areas like the caudates, the brainstem and midbrain areas. And so there's no single area. Similarly with alien limb, we see callosal lesions, some anterior callosum, some posterior callosum. We also see cortical lesions and subcortical lesions in the thalamus. So across both of these behavioral syndromes, we don't see a common localization. And so again, turning to the lesion network mapping approach, we see that in contrast to the lesion locations themselves, all of the lesions, 28 cases causing akinetic mutism, were functionally connected to the anterior cingulate cortex. And we saw this was highly specific in patients with akinetic mutism when we compared it to matched patients with hemiparesis. So these are patients that similarly don't make movements, but they do so not because they lack volition, but because they lack the motor output pathways. So they have intact volition, but impaired movement. Similarly, when we looked at disordered agency, so patients causing alien limb, we saw that the majority of these cases, so 90%, occurred in regions functionally connected to the dorsal precuneus cortex. This is a brain region that has been implicated in our sense of self and body. And we saw that that was also highly specific to patients with alien limb when compared to patients with hemichorea. So patients with hemichorea from lesions where they make what look like abnormal movements, but have an intact sense of agency. So really the contrast here being agency. Now, what are the implications for understanding psychiatric symptoms? And so to bring it back to psychiatry, there are many types of psychiatric syndromes that may involve aspects of abnormal perceptions of free will, of abnormal agency and volition. So in the case of catatonia, we have patients with abnormal volition where they often lack volitional or motivated movements. In the case of functional neurological disorders, whether that's psychogenic non-epileptic seizures, functional weakness, functional movement disorders, what these patients are describing are really a loss of volition for voluntary movements in the case of functional weakness, and a loss of the sense of agency for some of the movements that are being generated in the case of movement disorders or non-epileptic seizures. And so we didn't have individual patients to examine with these symptoms. We did have studies that looked at groups of patients with these different disorders where they reported neuroimaging abnormalities that related to those specific patients. So areas that had lower cortical thickness or brain atrophy, areas that showed decreased functional brain activity on PET scans or ASL scans. And what we were interested in is, are psychiatric patients with these disorders, do they have neuroimaging abnormalities that are occurring in similar locations to our brain lesion patients? And so can our brain lesion data and the networks we've identified help us to understand similar symptoms in psychiatric patients? And so what we did is we treated these study locations reporting abnormalities as lesions or as seed locations, and performed the same human connectome network connectivity approach to see across different studies, are we seeing similar locations? And so what this looks like is we take study locations that are reported to be abnormal across different studies. We determine the regions that are functionally connected to those reported abnormalities. And then we say, even if these abnormalities are reporting different locations in different studies, are they actually all functionally connected to the same brain network? So this is an example looking at this approach in Alzheimer's disease. Now here at the top, we have looking at these coordinates in different studies in psychiatric patients. And so in the top, we see that there are many different locations that were implicated that were associated with these abnormalities in catatonia, in psychogenic movement disorders. And really, both within each of these disorders and across them, we saw no consistent localization. But then at the bottom, we see in the red and the yellow that these locations were all functionally connected to a common set of brain regions. And what we show in the blue is a conjunction of our abnormal agency and volition networks. So the brain networks that seem to be implicated across disordered agency and volition. And we saw that these locations were occurring in locations that were connected to that same brain network, so that our lesion data was really helping us to identify regions that would be abnormal in patients with psychiatric diseases. And in column C, where we compared it to neuroimaging abnormalities identified that weren't related to these symptoms, we saw that it was specific to psychiatric patients with these symptoms, but not other types of patient groups. And so a final implication that we may have for some of this network localization approach is in terms of treatment. And so neuromodulation has been an emerging treatment for these neuropsychiatric symptoms. And that includes invasive methods like deep brain stimulation, but also non-invasive brain stimulation like TMS. And so TMS has been an improved therapy for depression, and work by my mentor and colleague, Mike Fox, has looked at the efficacy of these different locations of TMS to see if that matters in terms of how effective the treatment of depression is. And what he found is that those with treatment spots that are more effective seem to be more functionally connected to the subgenual cingulate cortex, an area that's been shown to be a marker or an abnormality in depression. And so the more anti-correlated the TMS target was, the more likely it was that there would be a treatment response. And so this suggests that neurostimulation may be a way that we can modulate this network, even if we can't stimulate the exact location we want. We may be able to stimulate locations connected to that region in order to get a behavioral change. And so we examined this for brain stimulation that seemed to alter free will perception. And so we identified different studies that had brain stimulation, either through neurosurgical mapping, where the patient was awake and getting neurosurgical mapping, or in TMS experiments. So different locations that when stimulated seem to alter free will perception or modulate it. And again, we found many different locations in the brain where stimulation seemed to alter free will perception. Again, we looked at where those locations were functionally connected to and saw that it was connected to a common set of regions that again overlapped with the disordered agency and volition network, this free will perception network we identified in patients with focal brain lesion. And so it suggests that this approach of network localization may be useful or informative for looking at different therapeutic approaches in neurological patients and also in psychiatric patients. And so in conclusion, what I've hoped to present today is evidence that functional disconnection syndromes can be tested with these new methods that combine the locations of structural damage in neurological patients with the human connectome, with that wiring diagram of the brain. And that using this approach, we can have better insight into the mechanisms leading to delusions, to criminal behavior, to disorder free will perception in patients with focal brain lesions. As Connor mentioned in the introduction, we're currently extending this approach to look at patients with dementia, frontotemporal dementia, Alzheimer's disease, looking at their patterns of brain atrophy and seeing, do these occur in locations that are functionally connected to specific networks? Does that explain the onset of similar symptoms in patients with neurodegenerative disorders? And I think that there are applications that this can have for understanding symptoms in psychiatric patients when those symptoms are similar, and potentially for developing new approaches to therapy. And then, as we discussed in the case of brain lesions and criminal behavior, implications for forensic work as well, in terms of understanding and interpreting brain imaging data in those cases. So I want to stop for questions, but I do want to really thank the people that have been really important to this work. Aaron Bowes and Mike Fox, as I mentioned, were the two that were working to develop this method when I became a fellow, and which we continued to develop throughout my fellowship. Other people at Beth Israel that were involved in my fellowship, Alvaro Pascaleon, Dan Press, and Mick Alexander, at MGH and the Center for Law, Brain, and Behavior, who have really helped with the neuro-law aspects of this, Bruce Price and Judy Edersheim. My current research team, Vanderbilt, Aaron and Tony and Jerica, who are helping with our current studies, my funders, and then my contact information there. But thank you again, Connor, for and the rest of the UCLA team for listening, and I'd be happy to take questions at this time.
Thank you, Ryan, for an outstanding presentation. I want to ask you a few questions that we have from the audience. The first question comes from Walter Dunn. Can you discuss the likelihood that an incidental finding in neuroimaging, a small cyst, one interpreted purely on anatomical location as unlikely to cause any functional impairments based on their size and location, may be resulting in downstream neuropsychiatric effects based on their network connectivity relationships?
Yeah, so that's a really interesting and challenging question. And so I think that the challenge, especially in these forensic cases, are incidental findings. And so we know that brain MRI can be very sensitive, but it can also detect changes that aren't clinically meaningful. And so, a challenge is determining how likely it is that abnormality could be resulting in the behavior. And so I do think that this network localization approach can be helpful in terms of saying that there's a low likelihood that lesion is contributing. So we did a short follow-up to our delusional misidentification paper, where we had some cases of delusional misidentifications that occurred in patients with a primary psychiatric disorder, a psychotic disorder. So patients with schizophrenia who had had delusions off and on, who then developed this, but were found to have a neuroimaging abnormality. And we felt like it was much less likely that the lesion location was what precipitated the delusion, because they had had delusions similar to this in the past. And we found that those lesions weren't strongly in locations, strongly connected to regions involved in belief evaluation and familiarity. So it seems like we may be able to use that in terms of its negative predictive value to say, this lesion is unlikely to be contributing. In the case of lesions causing criminal behavior, I focused here on cases where we had a very strong temporal association, where we knew the change in behavior had occurred at the same time as the brain lesion. We had other cases that we found where that temporal association was less clear, but it was still suspected. Cases where a brain lesion was found later after they've been imprisoned, but it was suspected that could have happened based on the history. And we found that the lesion localization in those cases matched with what we saw in the cases where there was a more clear temporal association. So I think that the challenge in terms of the positive predictive value is that there are going to be lesions that occur in these regions that are connected to this network that don't lead to that behavioral symptom. And so what we really need, in addition with the imaging, is a good behavioral characterization, that they have an acquired behavioral syndrome. It's not just this one criminal act, but it's other acts, and it's a consistent behavioral change that goes along with that, and potentially with support from neuropsychological testing. Although some of the neuropsychology tests may be insensitive for picking that up, we saw that the networks we saw important for criminal behavior weren't those that overlapped with executive control or cognitive control. And so some of those executive function tests may be insensitive in some cases.
Great, thank you. This question comes from Mohan Nair. What is your sense about a network dysfunction in persons with FTD with sexual misbehavior offending selectively versus a general criminality and impulsivity?
Yeah, I think that's a fantastic question. One thing we weren't able to do in these lesion cases was really further characterize, what types of behaviors are they having? And is that different for different, types of criminal or antisocial behaviors? We're in the process of collecting data like this in our FTD patients, where we're able to distinguish, whether there are these different hypersexual and sexually inappropriate behaviors, and whether those are dissociable from aggressive or violent behaviors or rule breaking in other contexts. Our preliminary data does suggest that there are differences in those symptom clusters, and we're exploring whether those relate to different network localizations. Now, it may be that there's one, that this network is broadly involved in antisocial behaviors, but that damage to certain parts of that may lead to that to manifest differently. Another possibility is that these are really truly dissociable localizations that have different brain networks involved. And a third possibility is that there are patient characteristics that lead to the different manifestations of that behavior, that it's part of the context, part of the underlying gender and age, or other factors that are beyond just the location of those lesions or the brain atrophy patterns that leads to those differences in the specific behaviors manifesting themselves. But we're hoping to explore that with this data, and hopefully we'll have a better answer for that soon.
Ryan, have you or others looked at people with non-acquired antisocial personality disorder, or people who score high on psychopathy and their brain networks in these different regions related to value-based decision-making or theory of mind, and comparing it to acquired?
Yeah, it's a really good question. People have definitely been looking for neuroimaging abnormalities in patients who have with psychopathic personality disorder or antisocial personality disorder. And oftentimes they are finding abnormalities that are in these same regions. And so different persons have had different hypotheses about the brain regions that might be affected. One school of thought has been that this is really related to amygdala dysfunction in those patients. Another school is that it's been more broadly affecting what's been called paralimbic or other limbic areas that largely overlap with the regions we identified. Now, as a construct, these psychopathic personality disorder, in addition to the antisocial behaviors, often has or is thought to have an affective component of reduced fear, reduced anxiety, and kind of abnormal judgments related to affect and interpersonal relations that may be dissociable from the antisocial behaviors. And so it may be that those are related to two slightly different networks, or that there are slight differences in psychopathic patients compared to these other cases. But I think, as you explore what's similar across that group with these other groups would be the antisocial behavior. And so, one of the future directions and one of the promise is to look at these different disease states. So FTD is one example, brain lesions, psychopathic personalities, some other instances where we get these behaviors, and saying, what's the kind of overlap that's common across all of them, because that may be what's specific to the symptom that's shared across all of them, even though there are other unique symptoms.
And it looks like we're out of time, but thank you very much, Ryan. I guess one last question that is coming up from several different people related to potential treatments. And I know you ended with the talk about brain stimulation. And do you see that as a model, or is that being researched to look into treating different issues, whether it's Capgras or other misidentification, or even certain types of antisocial behaviors in the future?
Yeah, I do think that brain stimulation could offer a very promising avenue towards that, because it gets a more localized effect, but it's still affecting a brain network. And so even the challenge with brain stimulation is that you may not have access to the locations that you really want to, but there are other instances where that might be really effective. We can also look at medications that may preferentially modulate brain activity in certain networks is another way of looking at that.
Well, thank you again very much for that excellent, thought-provoking presentation. And I want to thank everyone who is in attendance, and this was wonderful. Thanks.
Oh, great. Well, thank you again. And everyone feel free to email me if other questions come up.
Great. All right. Bye-bye.
All right, thanks.